Hello friends, let us now discuss the inflammations of the larynx. Let us first start with the acute inflammation of larynx, and the first disease that we have to study is acute epiglottitis. Nowadays, we say that not just the epiglottis is inflamed in this condition, but in fact the whole supraglottis is inflamed. Okay, so supraglottitis per se is a better term to use. However, acute epiglottitis is a traditional term we have been using for lots of years, so that is how this disease is known. Now, the most common causative organism. There is a controversy over here. The most common causative organism is Haemophilus influenzae type B Hib. But we know that now we have Hib vaccine. Now, because of the Hib vaccine, in some of the developed countries, the Hib infection rate has gone down. Okay, so therefore, in those countries, Streptococcus pneumoniae, also known as pneumococcus, has become the most common causative organism for acute epiglottitis. But you see, developed countries are few. Developing countries or underdeveloped countries are more in number. Developed countries do not have so much of infectious diseases compared to the developing countries or the underdeveloped countries. These are the countries which have the major caseload for infectious diseases. Okay, and therefore Streptococcus pneumoniae is not the most common causative organism worldwide. Worldwide, as well as India. India is a developing country. We still have Hib as the most common causative organism. Remember, even in India, we don't have the Hib vaccine as in the universal immunization program. Okay, so therefore Hib is the most common causative organism even today for acute epiglottitis worldwide as well as in India. Okay, so this is what the latest edition of Scout Brown also says. All right, now how will the patient present? This patient is generally a child. So this infection happens in child in the age group of 2 to 7 years. So how does the child present? It's an infection. Infection is in the throat. Patient has fever. Patient has sore throat. Okay, so you see 2 to 7 years old child, this child will obviously go to a pediatrician. Now a pediatrician in a day will see at least 10 to 20 patients who are having fever and sore throat. So is there something typical, something important that will raise the suspicion in the minds of a pediatrician? Yes. Okay, so other than fever and sore throat, the patient will have dysphagia, difficulty in swallowing. You see, we discussed quinsy earlier in the pharynx, and we saw that one side tonsil is inflamed and the child is having dysphagia. There the child can still swallow from the other side. Here the epiglottis is inflamed. So dysphagia is severe. Okay, how much severe? So much severe that the child is not even able to swallow its own saliva. All right, so the child may even be having drooling of saliva. Right? The child is having drooling of saliva. Then what else can be there? The epiglottis is inflamed and it may start blocking the airway. So if the airway is blocked because of this acute epiglottitis, this child may have dyspnea, difficulty in breathing. Okay, now because of that, to compensate that, the child may start having tachypnea, increased rate of breathing. Okay, and what else that can lead to? That can even lead to tachycardia. So when you examine this patient, you will see the patient is having dyspnea, tachypnea, tachycardia, and all of this will suddenly raise your suspicion towards acute epiglottitis. Okay, now most of the times when the child has come and the airway is getting compromised, the child would like to compensate for that. So what he will do? He will keep these two hands ahead and he will bend forward and extend the neck like this. Okay, this is known as tripod position or tripod sign. Okay, so by bringing the neck forward like this and extending, he's trying to place the epiglottis forwards and create some airway so that the child is able to breathe. Okay, so this condition slightly improves his airway. So therefore, the child will be found to be sitting in this. He's breathing through the mouth, as you can see over here. Okay, he's gasping for air and is trying to push the epiglottis forwards so that he's able to breathe. Right? Okay, so now what will you do? How can we confirm our diagnosis? You ask the child to open the mouth. If you ask the child to open the mouth, sometimes we see a red inflamed epiglottis behind the tongue. Okay, so as you can see over here, we can see a red inflamed epiglottis behind the tongue. Now remember, in children, the larynx is situated higher. So therefore, if we ask the child to open the mouth, we can sometimes see the inflamed swollen epiglottis behind the tongue. Right? Okay, so this is known as rising sun sign. Now, one rising sun sign I taught you in ear, in the glomus tumor. Now, this is the second rising sun sign seen in ENT, but this one is in the throat. That one was in the ear, and this is in the throat. Okay, so we have a rising sun sign, an inflamed epiglottis that is seen behind the tongue. Okay, now remember, in these cases, the laryngoscopy is contraindicated. In fact, not just laryngoscopy, even putting a tongue depressor is contraindicated. Why? Because the larynx is inflamed. It is swollen. And if you irritate it by any form of instrumentation, what will it do? It will lead to a collapse of the airway. Everything will contract and will shut down the airway. Okay, and the patient will go into sudden respiratory obstruction, complete obstruction. Okay, and that can be life-threatening. So remember, no instrumentation, any form of instrumentation is completely contraindicated. Right? Okay, so how will you diagnose? How will you diagnose this patient? Now, first, let's see over here. We diagnose this patient with the help of X-rays of the soft tissue neck lateral view. Now, these X-ray, we discussed a little bit about these X-rays in the previous topic, in the pharynx. I have taught you in detail when we studied about the adenoids. Now, let's look at the first X-ray. The first X-ray is the normal X-ray that I taught you in the pharynx. Okay, so for your revision, I'll just tell you that this is the airway we discussed in the pharynx, nasal cavity, nasopharynx. Then we have the oropharynx, the hypopharynx, larynx and trachea. Right? Remember, this is the uval and soft palate. You can see over here the epiglottis. You can see over here the hyoid bone, and over here is the epiglottis. Right? You can see the epiglottis is like this. It's a thin leaf-like epiglottis. Right? Okay. Now let's look in the second photograph. What do you see in the second photograph? You can see that this epiglottis, look, this is the hyoid bone and we have the epiglottis over here. This epiglottis is swollen like this. This is known as thumb sign. Okay, so this swollen epiglottis, this is known as thumb sign. So remember, thumb sign is seen in acute epiglottitis, and this is how we diagnose a patient of acute epiglottitis. We do X-ray, soft tissue neck, lateral view. So remember, X-ray, soft tissue neck, lateral view is the investigation of choice to diagnose acute epiglottitis. Okay, let's look at this X-ray. What do you see? Again, you can see that the epiglottis is swollen like a thumb. Now, what else do you see over here? You see that this vallicula over here, remember vallicula, the space between the epiglottis and the base of tongue. So if you look in the previous one, you will see that we have a thin vallicula going deep, whereas in this one, the vallicula is almost obliterated. It has become shallow. Okay, because of the swollen epiglottis, this vallicula is almost obliterated. Okay, so this is known as vallicular sign of acute epiglottitis. Here also you can see a swollen epiglottis, and you can see that this vallicula is almost obliterated. A shallow vallicula is seen, so that is the vallicular sign seen in acute epiglottitis. Remember, so we do a X-ray soft tissues of the neck, lateral view, to diagnose acute epiglottitis. We never do any form of instrumentation such as doing an indirect laryngoscopy or a fiber optic or a direct laryngoscopy or even putting a tongue depressor. All that is absolutely contraindicated, right? Okay. However, surgeons on and off, they try, they do something that they should never do, and this is what some people have tried. Okay, they try to do laryngoscopy to take a picture of the epiglottis or the supraglottis which is inflamed. So let's look in the first photograph. What do you see? You can clearly see a red inflamed epiglottis. Okay, so this is the inflamed epiglottis, and you see what has happened. The epiglottis has contracted. The whole supraglottis is contracted because of the instrumentation. There is absolutely no airway left. Okay, and look in the second photograph. Once again, you can see that there is no airway left at all because the larynx has gone into the contraction. So that is why I am saying that these are foolish attempts. We should never try to do these things. All right, because this can lead to an acute respiratory obstruction, and then the child may have only a few minutes to survive without oxygen. Right? So laryngoscopy, even putting a tongue depressor, is absolutely contraindicated. Okay, how will we manage a case of acute epiglottitis? It's a infection, it's a bacterial infection. So we have to give antibiotics, right? We have to give IV antibiotics. So we give ceftriaxone. This is the antibiotic of choice against Haemophilus influenzae type B. Okay, so we give ceftriaxone. What else can we give? We can give this patient steroid nebulization. Why steroid nebulization? The steroid nebulization will decrease the edema in the airway. Remember, you don't give IV or oral steroid, you just give a nebulization to decrease the edema and improve and open up the airway. Right? Now, sometimes this patient may present in stridor. So if patient of acute epiglottitis presents with stridor, remember stridor is a late feature in acute epiglottitis. That means the airway is almost completely compromised, and then you must immediately do a tracheostomy to save the patient. Okay, so tracheostomy is something that you have to consider immediately if the patient has stridor. Stridor is a late finding in acute epiglottitis. Right? Okay. Now, let's look at this question. A child with high-grade fever, okay, so child has fever, inspiratory stridor, and develops swallowing difficulty. You see, there is a fever, there is a stridor, okay, there is a stridor. So, respiration is compromised, the pathway is compromised, there is swallowing difficulty, and there is drooling of saliva. So, remember, anything that is affecting both the pathways, there is dysphagia and there is respiratory obstruction. So that means the problem has to be in the common pathway for food and air. So that means it can be in the oropharynx, it can be in the hypopharynx, or sometime epiglottitis, because epiglottis is also involving the parts of the pharynx. Since last 4 to 6 hours, right? Which of the following is recommended apart from general airway management, right? So you see child, high-grade fever, stridor, difficulty in swallowing, drooling of saliva. Now, drooling of saliva is very, very typical. So it points towards acute epiglottitis, right? That is our first diagnosis. So what will you do apart from management of the airway? You will give antibiotics. So which antibiotic will you give? You will give IV ceftriaxone. Yes, that was what I will do. Okay, what about nebulized racemic epinephrine? So we will not give epinephrine, rather we would like to give steroids, okay, to decrease the inflammation. Anti-diphtheria toxin not required. We are not considering this as diphtheria. For diphtheria, we need a lot of other things, and drooling of saliva is generally not seen in diphtheria. Okay, corticosteroids, they have not mentioned whether they are going to give it IV or oral or as nebulized. So our best answer in this question is therefore IV ceftriaxone. That is the best answer we have to choose. Okay, let's go to the next question. Therefore, considering the choices, IV ceftriaxone is the best option that we have to choose. All right. Now, before we go ahead to the next disease, let us first study a little bit about the surgical anatomy of neck. So we already know the neck anatomy. Just a quick revision. This over here is the hyoid bone. Below the hyoid bone you can see the thyroid cartilage. Below the thyroid cartilage you can see the cricoid cartilage, and between the thyroid and cricoid now we know that we have a membrane known as cricothyroid membrane. Okay, all right. Now below the cricoid we have the trachea, and over here you can see a marking, so that is the outline for thyroid gland, right? So remember, this is the anatomy in the central part of the neck, front central part. Now let us first talk about cricothyrotomy. What is cricothyrotomy? Cricothyrotomy is when we cut open this membrane, the cricothyroid membrane. So when we cut this membrane, we can directly enter into the airway, okay, between cricoid and thyroid. So when you cut this membrane, this is known as cricothyrotomy, right? All right. How do you identify this membrane? It's very easy, especially in males. So what you do is you identify the Adam's apple. Okay, so that is the laryngeal prominence. So you identify it. Now just below that there is a dip. There is a dip, and then there is a cricoid cartilage. So that dip is the cricothyroid membrane, right? All right. So what we have to do, we have to give an incision over here. So you give an incision, you directly enter into the airway. This is known as cricothyrotomy, when you give incision at the cricothyroid membrane. Now, when do we do cricothyrotomy? We do cricothyrotomy when we need an emergency airway control. Okay, so when we need to secure the airway in an emergency. All right, so emergency airway control. Now, where is the actual emergency? The actual emergency is not in the hospital. The actual emergency may be like a road traffic accident, all right, or patient has collapsed at home. The emergency is outside the hospital. It is not inside the hospital. Now, outside the hospital, remember, you don't have many instruments with you. You will not have a surgical knife with a surgical blade. You will not have a local anesthesia. You will not have artery and forceps to cauterize or control the bleeding or to catch hold of the vessels. So you need something that you can do immediately. It has to be quick and it should give a quick relief. All right. So what you do is you have this cricothyroid membrane. This is just below the skin. All right. So you identify the thyroid cartilage and you go below it. There is a dip. All right. Now there is no vessel in the center. So what you can do is you can take a knife. If the knife is not available with you, you can just take a pen. Right. Remove the cap of the pen and hold it in a dagger position. Identify the cricothyroid membrane. Stretch the fingers and you can stab. Right. When you stab, you will go into the airway. All right, so stab with a good force, you will puncture this membrane and you can go into the airway, and thereafter you can remove the refill. It's a ball pen. You can remove the refill and you can use that outer shell of the pen for a tube. Okay, as a tube you can use it for ventilating the patient. So that means this is a procedure which is used in real emergency, right, outside the hospital with the minimal instruments. You have a knife, very good. You don't have a knife, you can even use a pen to do a cricothyrotomy. All right. Now, see, thyroid, cricoid, in between you do your cricothyrotomy. Okay, let's come to tracheostomy. Now, what is a tracheostomy? Tracheostomy means you make an opening in the trachea. Okay, so now this is an opening made in the trachea. First thing, this has to be done in the hospital. You can't do it outside the hospital. Why? Because tracheostomy needs proper tracheostomy instruments, right? So instruments, surgical instruments are available in the hospital. Now in the hospital you do tracheostomy. There can be two types of tracheostomy. One is a planned, or you can also call it a routine tracheostomy. Okay, so you plan and you do a tracheostomy, and the other is a emergency tracheostomy. So tracheostomy can be done as an emergency procedure also, but it has to be done in the hospital. Okay, or you can do a planned or a routine tracheostomy. Now, second thing, where do you make this opening for the tracheostomy? You see, for the tracheostomy, you give a incision on the skin. Now, this incision can be a vertical incision, it can be a transverse incision. As you can see over here, this is a transverse incision going through the platysma. Now, if it's an emergency tracheostomy, you should prefer doing a vertical incision because that is a more bloodless plane, and if you give a vertical incision, the chances of your injuring the blood vessels or the bleeding is minimal. Right? A planned tracheostomy, suppose you're doing in the operation theater, you have the cautery machine and everything with you. So of course you can do a transverse incision also. So you have to go below the platysma. So once you go below the platysma, you can identify the strap muscles. Now what you do is, see, after this initial step, the step for emergency tracheostomy as well as the routine tracheostomy are same. Only difference is the incision, whether you are giving transverse or vertical. All right, the advantage of vertical incision is that the bleeding will be less. The advantage of transverse incision is that later on the scar will not be visible or it will be minimally visible. So that depends whether you are doing a routine or a emergency tracheostomy. Okay, so now you can see the strap muscles, and this is the sternocleidomastoid. Okay, the strap muscles, in the midline of the strap muscles, you just separate the strap muscles. Okay, so you don't need to cut them, you just move them away, and you see we have moved away the strap muscles. Now what can you see over here? This is a retractor place to move away the strap muscles, and we can see the thyroid gland, we can see the cricoid cartilage, we can see the first, second and third tracheal ring. Okay, now in this photograph we have shown that the thyroid cartilage is cut. So many people, they now routinely cut the thyroid gland at the isthmus and then they do the tracheostomy. Okay, I personally don't prefer to cut the thyroid gland. Okay, we can just simply lift it up and we can do the tracheostomy. So at the isthmus, you can just lift up the thyroid gland also and you can do tracheostomy. But of course, if there is a problem, you can always cut it. For cutting, you should have cautery and everything. So if you are doing a routine tracheostomy, you are in the OT, you have electrocautery and everything available with you, you can even cut the thyroid gland. If you are doing an emergency tracheostomy, you don't have an electrocautery with you to stop a bleeding thyroid gland, so it's better to retract the thyroid gland. Okay, so now either ways, once you see the tracheal rings, identify first, second, third tracheal ring. And now for a routine tracheostomy, what you will do is, see the cricoid cartilage, see the tracheal rings, you will give a cut between the second and the third tracheal ring. Okay, so you incise over here between the second and the third tracheal rings, you give an incision. If you need to remove, you can remove a part of the second tracheal ring cartilage. Okay, so you can remove a part of that also. All right, now over here I have shown a H-shape incision at the second tracheal ring also, so that can also be done in a routine tracheostomy. Okay, now sometimes we have to do a high tracheostomy. So what do I mean by high tracheostomy? High tracheostomy means you give an incision between first and second tracheal ring. Or if you have to remove a cartilage, you will remove the first tracheal ring cartilage. Right? So that is your high tracheostomy. Now, where do we do high tracheostomy? We do high tracheostomy in case of carcinoma larynx. Why we do high tracheostomy in CA larynx? That I will tell you when I will teach you CA larynx. But just remember that the high tracheostomy in case of CA larynx. Okay, what do we do in this? We give incision between first and second tracheal ring, or if you want to remove a part of the tracheal cartilage, you can remove the first tracheal cartilage, little bit part of the first ring. Okay, now let's look over here. After you have made an opening, you put in the tracheostomy tube. So once again, the tube will be available to you only in the hospital. So this is the tracheostomy tube. Okay, now you can compare this tracheostomy tube with the endotracheal tube. So endotracheal tube is placed from the mouth. Sometimes you can also do a nasal intubation also. So it is placed from the mouth into the airway, and the tracheostomy tube is directly placed below the larynx in the trachea. Directly you place this tracheostomy tube. Okay, Right. Now, this tracheostomy tube, just like the endotracheal tube, has a bulb which you can inflate and you can secure the airway also. Right? Okay. So now we come to the indications of tracheostomy. What are the indications of tracheostomy? So I call them as 5R. What are my 5R? The first R is respiratory obstruction. So something has blocked the pathway, just like we discussed the acute epiglottitis. So there is an infection, or there can be a tumor. Or remember we discussed in the congenital disorders, subglottic hemangioma. So there is a mass. There is a hemangioma, vascular malformation. So anything that is blocking the airway and the patient is not able to breathe, respiratory obstruction. Okay, so this forms an indication for tracheostomy. Number 2, respiratory collapse. Respiratory collapse. So what do we mean by respiratory collapse? The patient is not breathing. The patient is not breathing. So let's say the patient is in ICU. Patient is not breathing. So what do? You do a endotracheal intubation. Okay, and then you put this patient on ventilator. But you cannot keep this patient in the ICU for long time on endotracheal intubation. Why? Because a long-term endotracheal intubation leads to subglottic stenosis, leads to the formation of laryngeal webs. We discussed that. Okay, so between 3 to 7 days, 3 days to 7 days, the ICU in charge or the anesthetist on call will take a decision if the patient is supposed to be extubated quickly, like within 3 to 7 days. He may not do a tracheostomy, but if the patient is likely to stay for a long time in the ICU, more than 7 days, then the anesthetist may even after 3 days call you for a formal tracheostomy. Okay, so that's a case of planned tracheostomy. Right? So respiratory collapse, we do tracheostomy, especially when the patient requires long-term ventilation. The next is respiratory insufficiency. So what do I mean by respiratory insufficiency? Patients of COPD. Okay, what happens in them? Now, in patients of COPD, let's say a few of the alveoli are not working. So let's say 50% alveoli, I'm just assuming 50% of the alveoli have collapsed, they are not working. All right, now that means, let's remember some respiratory physiology. Let's say that this patient has a tidal volume of 500 ml. Okay, and we know out of 500 ml, 350 ml goes into the alveoli, 150 ml stays outside as the dead space, in the dead space. What is the dead space? Your nose, your pharynx, your larynx, your trachea, that's the dead space where the gases exchange does not take place. All right, so that means only 350 ml takes part in the gaseous exchange. Okay, that is the alveolar space volume. Now, I am saying 50% of the alveoli are not working. So that means 350 goes in the alveoli, but only 175 ml is the one that is involved in the gaseous exchange. Right? So you can see out of 500 ml, this is the effort the patient is putting in, and he's able to utilize only 175 ml. Okay, so approximately only 35% air is able to utilize. Now what you can do in this patient? In this patient you can do tracheostomy. So what is done in tracheostomy? You do a tracheostomy, you make an opening in the trachea, and now the patient is able to breathe through the tracheostomy. Now what happens? This tracheostomy decreases the dead space. Okay, it will decrease the dead space. It will almost bring it to zero. Right? So that means if the patient is now breathing 500 ml, the whole 500 ml or near about that is going into the alveoli. Okay, and you know what happens? Let's say the 50% alveoli are not working. Still the patient is able to do a gaseous exchange for 250 ml. So 50% he is able to utilize the air that the patient is breathing. So we can use tracheostomy to decrease the dead space. Okay, respiratory insufficiency. This is used in those patients of COPD or bronchitis where the patients are not able to maintain SpO2. Okay, if the patient is not able to maintain the saturation, oxygen saturation in the blood, then we do a tracheostomy to decrease the dead space. Okay. Next, respiratory secretions. So patient has a lot of secretions and patient is not able to cough them out. So you need to do repeated suctioning and cleaning of these secretions. All right. Otherwise, they will start blocking the airway. So we can do a tracheostomy to repeatedly doing the secretions. Again, this is generally done in the hospital settings to remove all the secretions from the trachea and the bronchi. Okay. Finally, to secure the respiratory pathway. Now, this to secure the respiratory pathway, this is done. Suppose there is a bleeding, there is a trauma. There's a trauma to the head and neck region and patient is having a lot of bleeding. This blood may go into the airway. Now, many times we do the endotracheal intubation and we secure the airway. But there are situations where you don't want to move the neck. Suppose there's a cervical fracture and you suspect that the bleeding may enter the airway. You can do a tracheostomy to secure the airway. Or let's say you have to do a oral or oropharyngeal surgery. And because you are operating in the pharynx, you cannot put a tube through that pathway. You have to do a tracheostomy to secure the airway and to give anesthesia. So similarly, there can be different situations when you have to secure the respiratory pathway, and tracheostomy is one of the methods that we use to secure this respiratory pathway. Right? These are the indications for tracheostomy. I call them as 5R. Now, what are the complications of tracheostomy? Now, the complications of tracheostomy, remember, the most common complication, or I will say the most common intra-operative complication for tracheostomy is hemorrhage, bleeding. So as I was telling you that we try to avoid the bleeding by giving a midline incision, especially in case of an emergency. Right? Okay. Sometimes people ask you most common post-operative complication. So most common post-operative, or rather I should say immediate post-operative complication is subcutaneous emphysema. Okay, so subcutaneous emphysema, there is collection of air below the skin in the subcutaneous tissue. Now this generally happens when the skin opening is little small. Okay, so when the skin opening is little small, so the air is not able to come out completely, the air which is coming out of the trachea, so some of the air escapes into the subcutaneous tissue and causes emphysema, right? So this is the most common post-operative or immediate post-operative complication, and for this the simple way is a little bit extend the incision, or if we have stitched the incision and we have applied some suture, so release one of the sutures and this emphysema will settle down, right? Okay, now let's come to this question. High tracheostomy is done in, we just studied it is done in carcinoma larynx. Why? I will be telling you in some time. Okay, let's come back to the topic of inflammations of the larynx and discuss acute laryngotracheobronchitis, also known as LTB, acute LTB or croup. Causative organism is para-influenza virus type 1 and 2. Okay, this is the most common causative agent. It's a virus, para-influenza virus type 1 and 2, generally seen in children. So this disease is also seen in children 3 months to 3 years old. 3 months to 3 years old child. Now, how will the patient present? It's a viral infection, okay, of the respiratory pathway. Which respiratory pathway? Involving larynx to bronchi, so lower respiratory pathway. All right, so the child has fever. Next, the child has sore throat. Okay, what else? The child has cough. Right, what kind of cough? Very, very typical cough, because the respiratory pathway, the lower respiratory pathway is blocked, so child will cough with a lot of effort. Okay, so this is known as barking cough. Okay, this is known as barking cough. Now this child may also sometimes have stridor. Now what kind of stridor can this be? Now you see the inflammation starts at the level of the larynx, right? It starts at the level of the larynx, goes to bronchus. So initially when the inflammation is at the level of the larynx, the stridor is generally inspiratory. Okay, so stridor is generally inspiratory. But when this, the inflammation, so it was there at the glottis, subglottis, it involves the subglottis, it goes to trachea, we can have biphasic stridor. Okay, and in some later cases, even expiratory stridor has been seen, right? So initial stages, it is inspiratory stridor, and then it becomes biphasic stridor when the subglottis and everything is inflamed and involved, and in some late stages, it can even become an expiratory stridor also. Okay, now, how will you confirm this diagnosis? Remember, 3 months to 3 years old child, where will the child go? The child is taken by the parents to a pediatrician. Okay, a pediatrician, but how will the pediatrician diagnose this condition? A pediatrician will ask for chest x-ray. Okay, so chest x-ray, when you do a chest x-ray, what do you see? You see that the airway becomes narrow. Okay, you can see this pencil tip narrowing. So this is known as steeple sign or pencil tip sign. Right? So this is the steeple sign or the pencil tip sign seen in the chest x-ray. Okay, you can see in this airway. So this will help you in the diagnosis of the acute laryngotracheobronchitis. Right? Let's look at this question. A 2-year-old child presented with following x-ray. So they have given you 2 hints. 2-year-old child, x-ray, and what is there in the x-ray? The x-ray is very typical. If they don't give you a lot of history, remember, if they don't give you a lot of history, so they will give you a typical finding. So you can see over here, this is a classical pencil tip sign over here. You can see the airway getting almost completely blocked over here. Okay, let's look at this. This is the x-ray, complete blockage of the airway. Right? So what is this? This is therefore a case of acute laryngotracheobronchitis. Right? Okay, this question was asked in the NEET PG January 2020. Remember, acute epiglottitis, you will have the thumb sign or the valvular sign. Both of them are seen in soft tissue neck lateral view. So here the view that is given to you is the PA view, or maybe the AP view is given to you. You cannot completely see because the X-ray is small, but it is not the lateral view. So acute epiglottitis is ruled out. Acute pharyngitis is a clinical diagnosis. You don't do any x-ray for that. Right? Now, parapharyngeal space abscess, once again, it's a clinical diagnosis, or maybe you can do a CT scan to diagnose it, but you don't do x-ray. You don't diagnose parapharyngeal space abscess on an x-ray. Right? Okay. So the answer to this question was, of course, acute laryngotracheobronchitis. Let's look at another question asked in the FMG June 2018 exam. A 2-year-old child presents with complaint of fever. So you see, now they have given a history. 2-year-old child presents with complaint of fever, barking cough, and stridor. So 3 things are mentioned to you, and clear-cut history, barking cough history. What is the most likely diagnosis? Remember, 2-year child will not have tonsils. Right? Tonsils start increasing in size at the age of 4 to 5 years. Right? Acute epiglottitis will not have barking cough. Can have fever and stridor, will not have barking cough. All right. Now, croup is therefore the diagnosis. Adenoiditis again is more common in the age group of 5 to 7 years. After 3 years, the adenoids start increasing in size. So your answer over here is clear-cut croup, acute laryngotracheobronchitis. Okay. So what treatment will you do for acute laryngotracheobronchitis? Remember, this is a viral infection. Okay, now this infection starts resolving on its own within next 2 to 3 days. So what treatment you will do? You will do conservative treatment. The patient resolves on its own. It's a viral infection. So by conservative, I mean symptomatic treatment. So whatever the symptoms are, accordingly, you will treat this patient because the patient improve on its own within the next 2 to 3 days. Okay, let's come to the chronic inflammation of the larynx. In the chronic inflammation, we have to discuss laryngeal tuberculosis. Right? Now, first thing about laryngeal tuberculosis. What's the first thing? This is almost always along with pulmonary tuberculosis. Okay, laryngeal tuberculosis happens almost always along with pulmonary tuberculosis. Generally, these patients are open or sputum positive cases of tuberculosis. Right? Second thing, there is formation of submucosal nodules. In laryngeal tuberculosis, there is formation of submucosal nodules, and this generally start in the posterior larynx. Okay, generally you can say in the posterior larynx or the posterior commissure area. That's the place where the formation of these submucosal nodules starts. Okay, now what happens? What happens? You can see over here that this vocal fold is inflamed. Okay, so you can see this vocal fold has become red. Anything else you notice? You can see the two vocal folds, they are not able to meet. There is a small gap. Now, there are submucosal nodules. Because of the submucosal nodules, the two vocal folds are not able to meet. We are not able to see the nodules at this time. But we can see that there might be some nodules. Because of that, these vocal folds are not meeting. There is incomplete adduction between them despite the maximum effort. Okay, so this is the earliest sign of laryngeal tuberculosis. The earliest sign of laryngeal tuberculosis is hyperemia of vocal fold with incomplete adduction. How will the patient present to us? The patient will present to us with hoarseness. Anything on the vocal fold, remember, anything on the vocal fold, the voice will start becoming rough, coarse. So that is known as hoarseness of voice. All right. Now this is the earliest sign that we will see when we do examination. There will be hyperemia, redness of the vocal fold along with incomplete adduction. Okay. Now what happens later? These nodules, they start becoming prominent. So when they start becoming prominent, they look like mammary glands. So we have a mammillated appearance. Okay. So as we can see over here, we have a mammillated appearance of the nodules. So these nodules are visible to us now. All right. Okay. What else do we see? You see, when these nodules, they spread to the vocal folds, because the vocal folds, they vibrate. So these nodules are shed off. So when they are shed off, what happens? So suppose this is the vocal fold, and once the nodules are shed off, what happens? There are multiple ulcerations. Okay. So you see over here, don't look at these arrows, look at this vocal fold below. And you can see that there are multiple ulcerations on the vocal fold. This is known as mouse nibbled appearance of the vocal fold. Okay, so mouse nibbled appearance of the vocal fold. And finally, these submucosal nodules, they spread to the epiglottis. So what do you see? You see over here that this epiglottis is swollen. Okay, it is swollen. It looks like there is an edema of this epiglottis. However, when we say edema, we means collection of fluid. This is not a collection of fluid. This swelling is because of the submucosal nodules. Okay, so we call this as pseudoedema of epiglottis, or you can even call it as turban epiglottis. Right? So these are the signs that we see in laryngeal tuberculosis. Okay, this is what we have to remember for your exam. The treatment of laryngeal tuberculosis is on the lines of pulmonary tuberculosis. So again, we divide the patient into different categories, 1, 2, 3, and accordingly we treat the laryngeal tuberculosis. Okay, let's come to the next condition, that is known as contact ulcer or contact granuloma. Now, contact ulcer or contact granuloma, number 1 is found in the posterior 1/3 of vocal folds. Okay, it is found in the posterior 1/3 of vocal folds. What do we have in the posterior 1/3 of vocal folds? Remember, in the anatomy, we have the vocal process of arytenoid cartilage. So it is found over there. Okay, now, secondly, what is the cause for this contact ulcer or contact granuloma? Now, the earlier cause, it was believed that this happens because of vocal abuse, vocal misuse. This happens because of long-term vocal misuse, and because of that the two vocal folds are rubbing against each other, and that causes the contact ulcer or contact granuloma. This was the earlier thought. Okay, but now the most common proven cause, which has been now been proven, is laryngopharyngeal reflux. Okay, LPR. So what is this laryngopharyngeal reflux? Now you see, the laryngopharyngeal reflux, LPR, you all must have heard GERD, gastroesophageal reflux disease. Now we all know what is GERD. The acid comes into the esophagus, right? Okay, so from the stomach, the acid comes into the esophagus. Now in many patients, this acid, when they sleep, this acid not only comes into the esophagus, it travels up into the pharynx, and from the pharynx it enters into the larynx. Okay, and that is known as laryngopharyngeal reflux, LPR. All right, and this LPR is seen to be the most common cause for contact ulcer or contact granuloma. Right, now this can present as a granuloma or it can present as a contact ulcer. You can see an ulcer also over here, but this is in the posterior 1/3 of the vocal fold. How will the patient present? Again, the patient has hoarseness. Remember, this is on the vocal fold, so patient presents with hoarseness of voice, right? Okay, number 2, look over here. Sometimes patient can even have bilateral contact ulcers or contact granuloma. Okay, right? Now, other than this, we have a category which is an actual contact granuloma, and that is the intubation granuloma in case of long-term endotracheal. This is because of long-term endotracheal intubation, and there is a trauma caused by the endotracheal tube to the posterior 1/3 of larynx. So you can see that there is formation of granuloma. In the first photograph, you can see unilateral granuloma. In the second photograph, you see bilateral intubation granuloma. Okay, what is the treatment for the contact granuloma? For intubation granuloma, you have removed the endotracheal tube, and these granuloma, they generally subside after that. Sometimes they may be infected. You can give a course of antibiotic. You may also give a course of steroid to decrease the inflammation. Right? Okay, a contact granuloma which is formed otherwise, that is because of the LPR, laryngopharyngeal reflux, you need to give proton pump inhibitors. Okay, so the treatment for most patients is proton pump inhibitors. All right, sometimes these patients also have vocal misuse, so therefore they may also need speech therapy to correct the way they are speaking. Right, so this is how we treat a case of contact ulcer or contact granuloma. Okay.